hopefully you guys can see that. And good morning. I know so last week we would have covered a little bit about lower limb 1, and we would have done a little bit on sort of the gluteal region plus the thigh region. I will just say that these sorts of topics, they're not so much separate as you might think, and we're going to be revising some of the content from last week just because a lot of the, like for example, the muscles and the blood vessels or the nerves actually carry forward down to the lower limbs and like the more distal aspects. So keep in mind that there will be some revision slides here, and I'm not going to spend too much time on them, but it's useful to keep those things in mind just as we go through the entire slide deck. And I also know that I promised to send my notes and stuff to you guys last week. I'm still trying to get that underway. So it's in the works, but just because university has been a bit messy, I haven't had that much time to work on it. And I'm sure my partners in crime agree that university has not been very forgiving. So I will try my best to get that up in a couple of days, but if not, I will let you know. Anyways, I'll get started. So lower limb 2. We're going to be focusing a bit on the knee and the lower leg now. And these are going to be sections that, again, will draw upon your knowledge from the last week. We're going to be using the same sort of style. So we'll talk about bones, muscles, nerves, maybe not so much vasculature because it's more of a big picture thing. And I'd recommend at the end of our entire section on the lower leg to actually discuss or like draw out all the different blood vessels so that you have an idea of how they relate to all these different regions. And we'll also discuss some of the regions. There's only really one that's really important here. And then finally, the most important thing, which is clinical relevance. Again, if you see this box anywhere, like the little gray box, that's probably the most important thing you want to take out of it. Or it's like a memory tool that I used to be able to remember something that was a little bit more complex. Okay, let's get started. So just as a quick review of last week, we discussed the femur as the only bone that's present in the thigh. And we did discuss some of the important landmarks that are more proximal. So this is only discussing the proximal aspect. We talked about the greater trochanter as being the insertion of some of the gluteal muscles, plus the piriformis, obturator muscles, etc. We talked about the lesser trochanter as generally being one of the major site of insertion for the iliopsoas. So that really big muscle that causes flexion at the hip. And then we talked about the pectineal line, gluteal tuberosity, and linea aspera. They're not so important, but the names kind of tell you what is happening at those regions. So pectineal is where the pectineus muscle is. Gluteal is where gluteus maximus lies. You can see some of these things on the diagram to the right. And then linea aspera is kind of where these two lines merge together. If you look at an actual diagram, pectineal line, gluteal tuberosity, they merge together into one linea aspera. And the linea aspera is where all the adductor muscles will attach. And so this is more on the medial aspect of your femur. So I'm not going to spend too much time on this, but it's a good idea to review it. We're going to focus more on the distal aspects. So what are some of the major landmarks here and why are they important? Because they mostly articulate with the knee. And the knee is our focus for this session. So thinking about things like the medial and lateral epicondyles, I want you to, like, whenever you have or you're studying anything in the lower limb, try and find something analogous in the upper limb, because that'll help you to understand what the relevance is going to be here. And obviously, because they both come from similar embryological origins. So that can help a little bit. So we're looking at the epicondyles, which are just above the condyles, right? You can see them being labeled. So medial epicondyle, just little projections coming off the medial side at the distal end. And then lateral is obviously on the lateral side. You can look at all the different attachments, but just remember that basically it's a landmark for attachments of certain muscles of the thigh, as well as some of the knee ligaments, which we're going to discuss in a couple of slides. The condyles are just below. And this is basically where you will have the articulation with the tibia. Remember back to when we were discussing upper limb, where we have the humerus, and it's mainly articulating with kind of one bone in the forearm, mostly the radius, and then the ulnar is kind of there. The radius and then the ulnar is sort of there for the rotation. Same here. You've got an articulation with the tibia. If you look at the fibula, it's kind of a much smaller bone. So it doesn't actually do that much in terms of attachments at least the proximal joints of the knee. But it is useful when you go distally at the ankle. And that's going to be something we will discuss later on in the next week. So for now, just remember that the main articulation at the knee happens between the femur and it's basically its condyles with the tibia. The adductor tubercle, as the name suggests, is going to be the place where some of the adductor muscles will attach. And that's going to be the adductor minimus and also part of the adductor magnus. And this is going to be the adductor part of the magnus. And the intercondylar fossa is where we will have several ligaments. So between the medial and lateral condyles, it's not very visible on this diagram because it's more on the undersurface. We might get a chance to look at it on the next slide, but it's between them in the middle. And that's where some of the, like you'll see ligaments that are within the knee will arise from this sort of fossa. Okay. Now looking at reviewing the muscles from last week, I'm not going to go into, again, a huge amount of detail, but just to give you a reminder that we've got 3 compartments in the thigh. We've got the anterior, medial, and posterior. And the way that they're divided is by the deep fascia or the fascia lata. But the important thing that I want you to get out of this is their distinct functions. And so this is obviously a general rule. There are some exceptions as we discussed last week, but the anterior muscles will generally flex the hip, extend the knee, and they're innervated by the femoral. All the medial muscles will generally adduct the thigh and they're innervated by the obturator. And most of the posterior muscles will flex the knee and extend the hip, and they will be innervated by the sciatic nerve. Now, why is this important? Because if you think back to your anterior muscles and some of your posterior muscles, you will realize that there are some muscles which not only act at the hip joint, but they also go down all the way to the knee. Again, if you think back to analogous structures in the upper limb, think about muscles like the biceps, right? Biceps is an anterior muscle that goes over the shoulder joint and also goes over the elbow joint, and therefore it acts at both of these joints. And same somewhat for the triceps muscle at the back. So we're going to be seeing a similar theme crop up in our study of the lower limb. Another quick word on the bones. So we're thinking about some of the bones within the lower leg, and the main bones here are going to be the tibia and the fibula. Now, for our studies, there's obviously many landmarks on each of them for muscles, and you've got this clinical relevance points. But for our studies, we're just concerned with the major functions of these bones. The tibia is the bone that will articulate with the femur, and that's what will form the knee joint, at least proximally. The fibula, again, just proximally, will not play too much of a role with this knee joint, but you can see at the bottom, like if you look down at the place where it says lateral malleolus of the fibula, you will notice that it actually has somewhat of a relevance with the ankle joint. And so that's what we will discuss next time. But for now, fibula is not so important. And reflecting the exact same things that we saw on the femur, the tibia also has its own sort of medial and lateral epicondyles. And this is kind of a jigsaw puzzle that sort of slots in with some of the complementary shapes on the femur. And then an additional bone, which is kind of special compared to, if you think back to upper limb, this is not really present there. In the lower limb, you've got an extra bone, which is called the patella. And so you might know this as the kneecap. It's a very small bone. Kind of paradoxically, the bottom is called the apex just because it points, has a bit of a pointy end at the bottom, and the base is at the top. So keep that in mind. The major important things or the relevance of this bone is that we've got 2 ligaments or tendons that come off either end. At the top, and this is where the relevance comes in for the thigh, is that you've got your quadriceps muscles, right? All your 4 muscles that are coming down and inserting onto the top of that patella, right? So it's inserting there, and that's the attachment of the quadriceps. At the bottom, you've got the patella ligament. And really, it's not a separate sort of ligament. It's kind of just a continuation of the quadriceps tendon. But the point of both of these is to stabilize the knee joint and ensure that the patella is at a good location to be able to protect the knee joint. Now, the patella doesn't just protect the knee joint. It has other functions. And I would encourage you to have a look, like if you want to search up online for what the functions of the patella are. It actually has some functions with unlocking some of the muscles of the knee. Some of the muscles of the thigh and the lower leg to be able to exert their maximum function. But for the most part, it is a protective bone. You've also got at the back, so on the posterior aspect, you've got facets. And these facets will articulate with the femur. So that's how it's able to stay in its relative position, not just because of the tendons keeping it in place, but also because of the shapes at the back that again act as jigsaw puzzles to keep it where it should be. Okay, now the all-important aspect is the knee joint. The knee joint is probably the most clinically significant joint in the entire body that you should be comfortable with. And this is not me saying this. This is actually like your faculty saying it in their documents, that this is probably one of the most important joints to become familiar with. And the reason is because there's a lot of pathologies associated with it. So if you go back to upper limb, you'll remember that the elbow joint also has a bunch of ligaments and bursae and stuff, but the knee joint is generally more easily damaged, and therefore you're more likely to see presentations of this in a clinic. It's because people, you look at sports people and things, everything involves running. If you are going to be tackled from the side, or you're trying to kick and you kick too hard or something, you're going to probably damage most of the things in your lower limb. And generally it's the knee joint because it's not the most stable joint. Although the body tries, it has hyoid limb cartilage to try and reinforce the joint. We've also got a lot of ligaments to be able to stabilize it, but these are not always effective. We've got three major groups of ligaments and a fourth one, which we'll go into in the next slide. The three major ligaments are the collaterals, cruciates, and the menisci. The collateral ligaments are sort of on the sides. You can see the green ones that have been highlighted. Those are your medial and lateral collaterals. Now, the MCL, so the medial one, is going to prevent valgus stress. Now, valgus stress, and I'll go into this in clinical relevance, is anything that pushes your knees inward. So if you imagine, I'm not really sure how to show this, but if you've got this, right? This is your, I know it's blurring out, but hopefully you can see my two pens like this. This is your femur at the top, and this is your tibia at the bottom. If you have anything that causes bending like this, that's either a valgus or a varus stress on the knee. If the stress is going inwards, so it's pushing your knees in medially, then that's called a valgus stress. And if there's anything that's pushing your knees outwards, then that's called a varus stress. And I've got a mnemonic to remember this because I know it's confusing, but you can imagine like why this is the case. If you think about a force being exerted from lateral to medial, you can see why the MCL would be protective against that. And then the converse is true for the lateral meniscus. If you have a force going from medial to lateral, the lateral meniscus is going to bend, or it's going to extend a bit and try and resist that motion, which is why it's so important for varus stresses. The cruciate ligaments are actually internal to the knee joint. So you can see we've got, again, two of them. You've got the anterior cruciate and the posterior cruciate. If you have a 3D model in front of you or some sort of app to be able to visualize these, you can see that the anterior cruciate ligament follows a specific direction. And that direction is good or useful because it'll prevent the tibia at the bottom from moving forward. It'll try and stop that movement of the tibia going forward and sliding past the femur. Same with the PCL. It has a specific arrangement that goes kind of backwards. You can see it kind of going into the page, and that's going to reverse or prevent reverse tibial dislocation. In other words, it's going to prevent things from going backwards. Really easy to remember. Like, you don't even have to understand this too well, because all you need to remember that ACL prevents anterior movement of the tibia and PCL prevents posterior movement of the tibia. So it's sort of in the name. And then finally, the menisci, you've got, again, two. So these are all paired structures. You've got the medial meniscus and you've got the lateral meniscus on their respective sides of the tibia. And they're mainly to act as shock absorbers. So if you jump up and down really hard, or you're just moving your knees a lot, you don't want the bones to keep on articulating with each other, because you're probably going to end up with some sort of distortion of the bones or damage to the bones. So they're kind of acting there to lessen the force that's being transmitted from one bone to another through its articulation. And they're sort of like, they're cartilaginous and they're very rubbery. So that's why they can reduce the amount of shock and force that's transmitted through the bones. One really clinically significant aspect to think about is on the medial aspect. You can see that the medial meniscus and the medial collateral are fused together. So you can see the purple and the green medial meniscus, they're both fused together. Whereas on the lateral aspect, you don't see that happening. The lateral meniscus is actually quite separate from the lateral collateral. Why is that important? Because if you have a pathology or some sort of, like, say, for example, you tear your medial meniscus, because it's connected to the collateral, you might also have a collateral damage to the medial collateral. This is not probably going to be seen on the other side. If you have a pathology in your lateral meniscus, it's unlikely to cause any damage to your collateral as well. So there's like this pathology where you have sort of a triple whammy. And I encourage you again to search that up, where you have some sort of damage to the meniscus, and that actually causes two other things to happen, which I won't talk about too much today. But it's because of this interrelated anatomy, because everything is joined together, at least on the medial side. Okay, now here's a way to remember some of these things, because I know it's confusing, especially with the cruciates, like the medial meniscus, lateral meniscus, they're named pretty intuitively. And so are generally the collaterals, because they're both medial and lateral. The cruciates are kind of confusing because they're internal and they don't have a straightforward pattern to the direction in which the fibers move. But you can think about this little mnemonic at the bottom, which is that whenever you think about the ACL, you want to think about palm. And palm just means that it's going from posterior to anterior. So it's going from back to front in a forward direction. And it's also going from lateral to medial. Another way, if you're more visually inclined, is to think about this picture. So you can see the fingers sort of going downwards like that. So if you think about your left hand, you make this arrangement, then your middle finger is going to be your ACL. It still follows the palm direction, but it's more visual. So you just take your hands like this, put them over your knees, so you can visualize where the ligaments are going, and your middle finger will always be the ACL and your index finger will be the PCL. Okay, so either way works, depending on which one you're more comfortable with. The other two images are just showing what I've reiterated before. So we've got the patella and the quadriceps. They're both, or the tendons of them, which are both continuous with each other over the patella. And that's just to ensure that the patella remains in its position. You've also got on the last image, the medial meniscus and the MCL, the medial collateral ligament. They're both fused together. So their fibers are fused, which can be quite clinically important if one of them is damaged. Another extra bit is the bursae. Again, very clinically important compared to the elbow bursae, right? Remember we talked about olecranon bursitis when you lean on your elbow for too long. A similar thing can happen here, but you generally won't, like if you think about leaning on your knee, there are situations where you can do that, but other times it can just be because you're overexerting some of the muscles that are sliding over the bursae. That causes irritation and inflammation of those fluid-filled sacs. Reiterating the fact that it's critical for smooth and frictionless motion of the joints, but if they become inflamed, then they can sort of do the opposite. So it can make all those motions a little bit more difficult. So here are the four main bursae that you want to become familiar with. There's also one at the back. So these are all just showing different angles, so you understand which ones are which. I would sort of ignore the pes anserine bursa for now, because I'm going to discuss what the pes anserinus is. The main ones are the infrapatella, so underneath the patella. You've got the pre-patella. And remember, when I say pre, it means before, but this is from my view. So if a patient is standing in front of me, this bursa would be in front of their patella from my perspective, which is why it's called pre-patella. And then suprapatella is above. And then you've got the one at the back in red on the left diagram, which is the semimembranosus bursa. The reason why it's called that is because it's behind the semimembranosus muscle, which is on the posterior aspect. Okay, so coming back to that pes anserinus, why is it important? Well, it's not so important clinically. It is the attachment. So it's the combination of three different muscles. It's anatomically interesting because those three muscles come from three different compartments. So I would encourage, if you can, someone, like if you've read the slide and you can see that they are the combination of the sartorius, the gracilis, and the semitendinosus. As a challenge, can someone in the chat write down which compartments these muscles come from? So is it medial, anterior, or posterior? And remember that these three will come from different compartments. So see if you can get that. But in the meantime, remember that if you're forgetting which muscles are involved, there is a mnemonic from anterior, it should say anterior to posterior, not anterior to anterior. It is say grace before T. So we're talking about sartorius, then we're talking about gracilis, which is in the middle, and then semitendinosus for T, which is at the back in the posterior aspect. It translates to goose foot, which I'm not sure is really that interesting, but it just looks like a goose foot. So that's why it's been called that. Maybe it makes it easier to remember. And I did mention that there was a bursa behind it. And we discussed the theme that, bursae will always be behind, generally behind areas where you've got a lot of friction happening. And if you've got three muscles coming together in one spot, and they're all trying to contract and relax at different times because they come from different compartments, that could be a potential space where you've got a lot of rubbing and friction happening, which can be quite painful. So that's why you've got this pes anserine bursa there as a protective mechanism. Okay. Hopefully someone in our team can just check the chat because I can't see it right now, to make sure that all the muscles are in the same, or like you've correctly identified which compartment they come from. Okay. There are also a couple of extra joints, and you may recall back to, I'm always coming back to upper limb because that makes things a lot easier, at least for when I was studying. You think back to upper limb and you think about, yeah, you've got the elbow joint, you've got the wrist joint, but those are not the only two joints that are present in the distal aspect, right? If you think about the articulations between the radius and the ulna, you've also got two radio-ulnar joints, both proximal and distal. Same with the lower limb. You've got the tibia and the fibula. They also articulate with themselves at three sort of major spots. You've got the proximal TF joint, which is obviously at the proximal aspect. You've got the distal TF joint. And in the middle, you've got this interosseous membrane. We didn't spend too much time on this in upper limb, but it's also there. It's present in both the upper limb and the lower limb. And in the lower limb, it's actually quite clinically relevant because it can act as a place where you can inject anesthetic for targeting a specific nerve. Now, the proximal TF joint and the distal TF joint, they're not technically the same, or they don't have a similar sort of structure. The proximal one they're both plane joints. So that means that they can only go like sort of sliding direction against each other, which is similar to the radius and the ulna. The radius or the ulna can only slide around the radius, right? But the proximal one is a hyaline cartilage joint, whereas the distal one is hyaline cartilage, but it doesn't have a joint capsule. So in other words, you could say the proximal TF joint is a typical synovial joint because it contains synovial capsule, which produces fluid, but the distal TF joint does not have a joint capsule. However, that is not really so high yield. The main point to kind of remember is that they both allow very limited movements. So as I alluded to, you can only get sort of this plane movement where you can get one bone rotating over the other. And if you try and do that with your leg right now, where you just kind of go in and out, like rotate your lower limb, you'll notice there's not that much movement that you can get out of it. So clinically, if you try and overexert yourself, you can get breakage of these tibiofibular joints, but it's very uncommon, given the fact that you can see there's so many ligaments that are trying to stabilize those two joints. Now the muscles, there's many, right? Similar to the thigh, you've got three compartments. The only difference is that it kind of switches over. So remember, you have the anterior, medial, and posterior compartments in the thigh. You've got a very similar thing, except instead of medial, you've now got a lateral compartment. So it kind of switches around like a mirror image. Now, general rules still apply. If you think about anterior muscles, and I know this is a bit forward thinking just because we haven't really covered the motions of the foot yet. So it might be difficult to explain, things like dorsiflex, invert, and all these different terminologies, but I'll try my best to just talk about them a little bit. If you think about all the muscles that are at the front, they're going to be going down to the foot. And if they contract, they're going to cause your foot to kind of go upwards like this. And that's called a dorsiflexion. Okay, so that's dorsiflexion. And another thing that they can do, which we'll see with some of the muscles, is invert the foot. So there's another terminology, invert and evert, which we'll go into a little bit later. However, the anterior muscles will always be innervated by deep fibula. All of these nerves that I'm telling you, deep fibula, superficial fibula, tibial, they all come off the sciatic nerve. So remember that you've got femoral, obturator, and sciatic nerve all in the thigh. The other two nerves will sort of end sort of there. Maybe they'll give us a couple of cutaneous branches, but it is mainly the sciatic nerve that continues down, splits into a common fibula and a tibial, and then the common fibula further splits off into deep and superficial. That's where we get these three nerves, and they will all innervate the different compartments. So the anterior is the deep fibula. The lateral muscles on the lateral aspect, they're generally to evert the foot. And if you think about something that's on the lateral aspect of your lower limb, or the distal aspect of your lower limb, and it's contracting, it's going to cause your foot to kind of shift outwards, and that's called eversion. Okay, so most of these muscles will do eversion, and there's only really two that are important. And then finally, the posterior muscles, if you imagine they're at the back, attaching down to the bottom of the foot, if they contract, they're going to cause your foot to go downwards like this, and that's called plantar flexion. So if you plant your foot downwards and you push it even further downwards, that's called a plantar flexion. Another thing that they can do similar to the anterior muscles is invert the foot slightly. But for the most part, if you just want general rules, anterior is going to dorsiflex the foot, lateral is going to evert the foot, and posterior muscles are going to plantar flex the foot. And a general extra thing that the anterior and posterior can do is also invert. Because you've got eversion in the lateral muscles, you also need something to invert. And the posterior muscles will be the tibial. Okay, now onto the muscles. I'm not going to spend a huge amount of time on this because you are probably already familiar with the naming conventions. So you know what something like extensor means, you know what longus means, you know what digitorum means. Just a couple of words that you may not be familiar with are things like hallucis. So remember in the upper limb, we had pollicis, that was for the thumb. In hallucis, this is for the big toe. Everything else is very much the same. Tibialis, that tells you that potentially it's either originating on the tibial muscle, on the tibial bone, or it's inserting somewhere onto the tibial bone. Same with fibularis. I'm trying to see if there's anything important here. Oh yeah, the fibularis tertius. It's not something that's like in some textbooks, it's not even talked about because they consider it to be part of one of these other three muscles. But I would still encourage you to have a look and think about what its specific action is going to be. And the reason why is because it's a bit of an exception to the other three muscles. Remember I said that most of them are going to dorsiflex and invert. The fibularis tertius actually does a bit of eversion, which is why I feel like a lot of textbooks are scared to talk about it. But it is important because it is a little bit of a exception. Yeah, and innervation is by, as I said, deep fibula, which goes from L4, L5, S1, and S2. It is a division of the common fibular nerve, which itself is a division of the sciatic, as I discussed previously. Okay, now onto the lateral aspect. There's only really two muscles, the longus and the brevis fibularis. The first one is going to cause mostly eversion and a bit of plantar flexion just because of the way it inserts at the bottom of the foot a little bit. Whereas fibularis brevis, because it's not as long, it'll only really cause eversion. So it's only just attaching to the side. And here was that diagram that I promised you. So inversion is going into the medial aspect. So if you imagine this is the foot, both of my feet, and they're going inwards like this towards my midline, then that's inversion. If they're going outwards, then it's eversion. If I go up, then it's dorsiflexion. If I go down, then it's plantar flexion. And these are going to be innervated by the superficial fibular nerve, which is actually L4, L5, S1, S2. And again, a division of the common fibular nerve. The posterior aspect is actually a little bit more straightforward, although there's more muscles to talk about. The posterior is divided into superficial and deep. Superficial are very, very straightforward. You can remember them with the mnemonic GPS. So you've got gastrocnemius, you've got plantaris, you've got soleus. And if you have a look at gastrocnemius, it's actually got two heads. So you can feel these as your calf muscles. If you try and feel the back of or you feel your calf, you can feel a lot of these muscles. And if you try and maybe dorsiflex your foot, you might be able to feel these muscles actually become a lot tighter because you're extending those fibers out a lot. So you can feel these muscles. The only muscle that you probably cannot feel as much is the plantaris because it's a little bit deep to the gastrocnemius and it's extremely minor. As I mentioned, all these muscles will do plantar flexion, but plantaris, if you were to remove it, it wouldn't actually make a difference to the amount of power that you can generate from plantar flexion. I think that's the reason why it's used a little bit in reconstructive surgery. So you can remove the plantaris and then use it somewhere else to, I don't know, reconstruct part of your face or something. Not that I'm a plastic surgeon, but I believe that's the reason why. So it's not so critical. The other ones, though, are very, very important, especially gastrocnemius. In fact, it has two heads, right? So it's generating the most amount of power. These muscles will be innervated by the tibial nerve, which goes from L4 to S3. And this nerve is a branch of the sciatic nerve. The deep muscles are kind of reflections or the opposite of some of the anterior muscles that we discussed. So popliteus is the only exception. It's a smaller muscle and it's going to unlock the knee for flexion. So you imagine you've got your tibia, fibula, you've got a plantaris muscle at the very top. It's not really demonstrated on this diagram, but if you imagine at the knee joint, it's basically just there. It's confined to that region and it's kind of like this rectangular sort of shape. And all it does is, if you are in a position that's not suitable for flexion of your knee, it'll shift the bones around so that they are adequately located to be able to allow flexion to occur, so that you've got no grinding of the bones happening. So that's the main function of popliteus. And you can think about its analogous structures, for example, anconeus and supinator in the upper limb. Flexor digitorum longus is very similar to extensor digitorum longus. It's going to flex some of the toes, and flexor hallucis longus is going to flex the greater toe or the great toe. The main thing here to discuss in terms of, like, if you go into some of your specimens sections, you might expect your flexor hallucis longus to be close to the big toe, right? Or at least on the side of the big toe, so that it can allow flexion of the big toe. And then flexor digitorum longus to be closer to the other toes. This is not the case though. And so it's a bit of an exception, which is why you should be careful when you go into specimens. It's actually on the further side from the big toe. So have a look at the rightmost diagram shown. You can see that you've got the big toe on the left, but you've got the flexor hallucis longus and its body actually on the right. And the reason why this makes sense is because the further sort of you are from that particular insertion point, the more force you'll be able to generate when you contract. So because it's going at sort of an oblique angle, it's going to cause much more of a contraction than if it was on the same side. Okay, so that's something, it's not important clinically, but it's very important for specimens. If you're looking at trying to identify all the muscles on the posterior deep aspect of the lower leg, you should be able to recognize that hallucis is actually more lateral to the toe. And then tibialis posterior is very similar to another muscle we already discussed, tibialis anterior, except it does the opposite. So it's going to cause inversion as well as plantar flexion. These are also innervated by tibial nerve, which is a branch of the sciatic nerve. So everything posterior is going to be tibial. Now, areas. We're talking mainly about the popliteal fossa, which is basically analogous to one of the structures. Let's see if in the chat you can recall the name. But one of the structures right here, right? We've got that structure there, which is basically just a place where neurovasculature and some muscles can attach to. A similar thing happens in the knee, the popliteal fossa. This time it's diamond shaped and it's on the back of the knee, so not on the front of the upper limb. And again, this is to do with rotation during embryology. So the knee sort of faces, this part will sort of face backwards, whereas in the upper limb it faces forwards. The borders are very straightforward to remember. It's diamond shaped, right? So you can have a go at drawing out a little schematic for yourself. You've got superolateral, so top, and then on the lateral aspect, that border of the diamond is by the biceps, the long head of the biceps femoris. On the medial aspect at the top, you've got the semimembranosus. So these are both muscles on the posterior thigh that attach down into the lower leg. And then you've got the infralateral and inframedial. These are both formed by the heads of the gastrocnemius. Again, it's divided into two heads, right? So they both form these walls or these borders at the bottom aspect of the diamond. But an extra muscle that can contribute to the lateral bottom is the plantaris. Remember that really boring sort of, not useless, but not as strong muscle that does contribute a little bit to the infralateral border. But for the most part, just think about the big muscles, biceps, semimembranosus, and both of the gastrocnemius muscles. I think there's a mnemonic somewhere, but I couldn't find anything in my notes. So if you can think of a mnemonic for this, that's an added bonus, just to make sure you don't forget what the borders are. Contents are probably a little bit more important for your specimens. So if you've got a dissection opening up the popliteal fossa and they're asking what goes through it, can you identify what is the artery, the nerve, the vein, then it's important to remember the order in which these occur. So you've got mostly neurovasculature, which involves the popliteal artery, popliteal vein, tibial nerve, common fibular nerve. Let me just dissect, no pun intended, let me dissect this a little bit further. You've got the nerves, right? So the sciatic nerve was at the top in the posterior aspect of the thigh. It came down sort of just before the popliteal fossa. It will split into the tibial nerve and the common fibular nerve. This is where it happens. So that's why you can see those two nerves there. After the popliteal fossa, the common fibular nerve will then split into the superficial and deep. And then all three of those nerves, those terminations of the sciatic nerve, will innervate different muscle compartments in the lower leg. So that explains the nerves. The arteries remember that they're basically the same as, or they're continuations of the femoral artery and the femoral vein. They've just been given a different name because of the region that they're in. And that makes it easier for you to describe where specific pathologies are. But popliteal artery is just the same as the femoral artery going into the popliteal space. And then the femoral vein, so the popliteal vein will drain into the femoral vein, which will then drain upwards and more proximally. So they're the same structures, just with different names. Some other things you might have is a bit of fat, and that will just allow for better movement of the knee joint. And also just to make sure that all these structures don't compress each other, because that would cause, for example, it may cause structures distal to this popliteal fossa to lose their blood supply, which is obviously not good. As a general rule of thumb, if you're thinking about your dissection and you know which side is medial and which side is lateral, then you will follow the order of AVN. So you've got the popliteal artery first, and generally this will be, I think, a little bit more deep to the popliteal vein, correct me if I'm wrong. But you've got the artery, then you've got the vein in the middle, and then you've got both the nerves happening more laterally. So if you're ever confused, think AVN. Okay, finally, on to a bit about clinical relevance. We'll talk about first fractures. So we're thinking about bony structures. Patella fractures are very straightforward. With the patella, you can have all these different types of fractures happening. Some fractures will cause, depending on how traumatic the experience was, it can cause the entire patella to kind of break up into all the different fragments. And so it's kind of unpredictable what will happen with those fragments. But if you've got a straight trauma that splits your patella into two sections, think about the anatomy, because what you've got is at the top, you've got the quadriceps muscle, which is trying to contract, right? And you've got the patella tendon at the bottom, which is also trying to pull down. And if you break the division between the quadriceps tendon and the patella tendon, they're both going to pull in opposite directions. So you'll get half of the patella going up and half the patella going down. When both of the patella, the patella was sort of just one object rather than being broken up into two pieces, this is not a problem because both of these forces counteract each other. But when it's broken up, they will definitely cause both of the pieces to go in opposite directions. And so you can see that in the imaging. You can see it's been split and also been pushed away from each other. And this does leave the knee kind of vulnerable to more damage, which is why you need to make sure that this has been properly protected by some other means. Fibular fracture is very critical. This is super high yield. So you think about the fibula, and I did say, it's not that important for forming the knee joint, and it's not so important for just the area that we're discussing. But one clinically relevant aspect is that the common fibular nerve, which over in this diagram is called the common peroneal nerve, it's the same thing, will wrap around the head of the fibula before it splits into its superficial and deep components. If you do have some sort of fracture to the head or neck of the fibula, then that risks damage to that specific part, the proximal part of the common fibular nerve, which will mean that you will have denervation to the deep fibula as well as the superficial fibula. Again, think about what these two nerves innervate. The deep fibula will be the anterior compartments of the lower leg. So all those muscles that are responsible for plantar flexion are no longer going to work. The less clinically relevant one is going to be the superficial fibula, which is more responsible for the lateral muscles or eversion. You won't generally see that present too much, because if you try and evert your foot right now, you don't have that much eversion capacity. So no patient will typically notice that they've lost their capacity to evert their foot, but they will definitely notice when they're not able to plantar dorsiflex their foot and bring their foot upwards. And we'll discuss what the clinical consequence of this is when we go into the next slide for nerve damages specifically. Oh, and also the reason why I'm talking about fibular fractures and not tibial fractures is because of the fact that the fibular bone is much thinner and also less protected, because it's kind of more superficial, which means if I was to just knock you, punch that bone or kick you accidentally on the side of your leg, I would never do that. But if I did, then that would cause immediate damage to the fibula because it's so weak. Whereas the tibia is such a thick bone that even if I was to hit it, and you can, actually, I don't think I should recommend this, but if you try kicking yourself, I guess, I don't know, if you try kicking yourself on the side that has the tibia on it, you'll feel how strong that bone is. It's very difficult to damage that bone. So generally the fibular fractures are more common. Okay, So I promise we'll talk about common fibular nerve, and this is where it comes up. So I'm talking more generally about common fibular nerve palsies where it's been damaged. This can be because of the fracture of the fibular neck, or another really important one to keep in mind is if I've got a broken leg and I've put a cast on, if that cast is too tight or it goes up too high, then I might get compression of that nerve without actually having any damage in the region. So both of these situations can cause irritation to your common fibular nerve and therefore injury. Now, I talked about the motor parts, right? How that's important. And we talked about the fact that because you've got damage to common fibula, you're going to have damage to the deep fibula, which is not going to be able to allow for dorsiflexion of your foot, which means that you're going to have unopposed plantar flexion. So you're going to have your foot just limping down like this. And if you look at patients who are walking that have this sort of palsy, because they're not able to, when they're walking, they have to lift up their foot, right? And if they're not able to do that, you'll notice that they try to fling their foot forward to be able to kind of manually push it upward. So you'll kind of notice this characteristic. I'd encourage you to watch a video because it's quite characteristic of this sort of condition, but they'll try to flick their foot upwards, and it's called like a toe flick to be able to keep on walking. So that is because of the damage to specifically the deep fibular nerve and not so much the superficial fibula. The other aspect that's important will be the loss of sensation. So this is just an image. This is more detail than you will ever need to know, at least for first year, regarding the cutaneous innervations of the common fibular nerve. The main point I want you to get out of this is that you can see how extensive the innervation is, not only on the anterior part of the lower leg, but also the posterior part of the lower leg. So this person is probably going to experience either decreased or complete loss of sensation in these areas, which is more readily, like available for patients to understand and feel than the motor aspects might be. So this is something you can test during a clinical examination. If they've lost sensation around these specific dermatomes, then you're thinking, okay, there might be something causing the common fibular nerve to be irritated, specifically its sensory components. Bursitis. So analogous to our olecranon bursitis back in upper limb, we've actually got many different types of bursitis that can occur depending on which bursa is irritated. And there's a reason why you can get different bursa being irritated. So if you think about the infratellar bursitis, the infratellar bursa, patella bursa, is underneath the patella. So if I've got, this clergyman's position where they're kind of kneeling down and the bottom of the underside of their knee is rubbing against the ground continuously, this is like a daily thing that's happening, then you might get irritation of that specific bursa, which is called infrapatellar bursitis, or otherwise known as clergyman's knee. The same thing can happen if you lean on the more, directly onto your patella. So if you directly lean on your patella, then you're going to cause irritation of the prepatellar bursitis, which sits right on top of it. And this is classically called housemaid's knee because of the position that the knee can be in when you're, like, for example, kneeling down to clean the floor. Semimembranosus bursitis is perhaps the most clinically important one, because not so much because of the fact that it's inflammation of the semimembranosus bursa, but because you've got this other pathology called a popliteal aneurysm, which is when you've got inflammation or expansion, abnormal expansion of the popliteal artery. It may be difficult to tell whether that's popliteal aneurysm or whether that's just a Baker's cyst, so inflammation of the semimembranosus bursa. So there are ways that you can tell that these are different. For example, if you try and feel on the Baker's cyst, it might feel a lot more dense because of the fact that it's filled with fluid and it's being irritated, compared to a popliteal aneurysm, which you might be able to actually feel is pulsating, right? Because obviously blood is going through it. Whereas with a Baker's cyst, there's no blood. So there's ways you can tell, but visually it can be quite difficult. Either way, this can be very painful. So Baker's cyst, if you have one and you make the mistake of, for example, like flexing your knee really hard, you can actually pop that Baker's cyst, and that can cause like compression to the rest of the region. And you have a lot of stuff happening in there, right? You've got arteries, nerves, and things. So if you get eruption of that Baker's cyst and you get compartment syndrome, you're going to cause irritation to all those structures, which is not a good outcome for the patient. And finally, just ending off on some things on the ligaments. we're thinking about all the ligaments, and remember what I said with the cruciate ligaments, with the collateral ligaments, they also have a purpose. For example, the cruciate ligaments are trying to prevent the tibia from moving against the femur. So the ACL, I mentioned that it's preventing, it says ACL, right? Anterior. So it's preventing anterior movement of the tibia. And you can see that with the tibia in this diagram, it's trying to move forward, but the ACL is going to try to prevent it. However, if you get too much movement of the tibia against the femur, so you get it moving way too far ahead, then you will get that ACL to tear. Now, generally speaking, and this is where it gets a little bit confusing, so I'd encourage you to revise this again. Generally, when you get a tear, you can imagine that, like if you imagine a sports person who's running really fast and then suddenly decides to stop, right? They suddenly decide to stop. Their tibia is going to be fixed on the ground most of the time. It's actually the femur that shifts against the tibia because their body is still trying to move forward, but the leg is fixed. So in this case, it's kind of the opposite. So ACL limits anterior movement of tibia, or in other words, it limits posterior movement of the femur against the tibia. And that's what's actually going to happen clinically, where you've got the tibia being fixed and it's the femur that's moving, not so much the femur being fixed and the tibia that's moving. So the ACL will be damaged if the tibia is fixed and the femur moves backwards. Similar thing with the PCL. Generally, PCL will prevent posterior movement of the tibia against the femur. But if the tibia is fixed, then really what's happening is to get that sort of movement happening again, you will need to get the femur to move forward. And that's sort of replicating the same scenario where you will get a tear of the PCL because it's not able to resist that motion. So again, review this because it's important. I think you will come across this in a tutorial somewhere. And it's a bit of a trick question, so keep it in mind. Collateral ligaments are much easier. So I did mention that it prevents valgus or varus stresses. If you've got too much valgus stress, too much varus stress, you're going to tear the ligaments. This slide is more so to show you visually what that looks like, and also to give you a useful way to remember what is valgus and what is varus. So if you don't remember valgus, just think valgum, and gum is going to cause your knees to sort of stick together. So it's getting your knees to point inwards, whereas or varus is like varum. So you've got a bottle of wine or something between your legs, which is causing your knees to be shaped outwards like a diamond. So if you forget, that's where it is. But just remember that if I've got a valgus stress, it's going to cause the medial side or the medial collateral ligament to have quite a bit of stress on it, and it's going to have potentially tearing. And the second thing is, it's not shown in this diagram so much. The medial collateral ligament is linked to the medial meniscus. Remember that. So if I have a medial collateral ligament tear and it's close to where it connects with the medial meniscus, then we can have damage to both of them. That's very, very important to keep in mind. And then finally, the meniscus ligament tears. Remember that these are just the cartilaginous structures that are preventing too much friction between both of the bones that are articulating to form the knee joint. So generally, it tends to affect the medial meniscus. And the reason why is because it's fixed to the MCL. So if you've got pathology in either, you're going to more likely impact the medial meniscus than the lateral meniscus, which is not connected to much. And the kind of bad thing with these sorts of injuries, if it's not treated, is that because it's made of cartilage, and cartilage is generally avascular, you're going to have very poor prognosis for recovery, unless you go in and then try and replace the cartilage with something external. So it's not going to be able to repair itself is the sort of the main point to get out of this. Okay, and I think that's it. One extra thing I wanted to talk about was popliteal aneurysm. There's not a slide on this specifically, but if you go back to our discussion of the semimembranosus bursitis, it will look like that. The only thing that is different is it's an artery, not a bursa. And there are many reasons why that specific artery might be dilated more than it should be. And you'll see the word aneurysm come up so often, like aortic aneurysms, you'll have aneurysms in the brain. Basically, any artery that might have too much flow happening through it, or there's some sort of structure more proximal that's preventing blood from exiting through that artery and going upwards, might cause blood to build up there and cause an aneurysm. The main important thing here is just to distinguish that from a Baker cyst. And usually the differentiating factor is going to be that the popliteal aneurysm will have a pulse. There's blood running through it, so there'll be a pulse, whereas Baker cyst will not. So hopefully that helps to allay any confusions that you may have had with your studies of anatomy this week. If there's anything else that you want help with, please let me know in the chat. I can already see there's a lot of messages, so I'll read them. But in the meantime, yes, it is cubital fossa. Very good. So in the meantime, I'll pass it on to the next topic. Thank you very much.
Thanks so much, Janam. So hopefully you guys, internet. Hopefully you guys can see the slides at the moment. All right. So I'm going to talk about anti-inflammatory agents. So when we are thinking about targeting inflammation, the primary method that we have for doing that is by targeting the mediators of inflammation. So inflammation is a complex process. It involves a lot of different things in your body. We can theoretically try and directly treat the symptoms, but that's not particularly useful to us because we want to try and get it at least the immediate causes. So dealing with the actual causes of the disease is its own issue, and that'll usually be linked to the specific disorder which is causing the inflammation. These drugs focus on the intermediate steps. So we have the initial cause, we have the intermediaries, and then we have inflammation. We're trying to knock out that middle step. So the target group of signaling molecules that we go after is called eicosanoids. Oh, sorry, eicosanoids, I think. Not sure how you pronounce that. There are two main groups in that sort of umbrella, which is prostaglandins and leukotrienes. Okay, all of these are lipids. They all come from phospholipids, so they just get modified in the body through various pathways. So what do we do when we want to knock out inflammation? Is we actually prevent steps in that pathway. So by blocking the conversion of phospholipids and similar substrates into eicosanoids, we can prevent cells from being able to create those mediators, which means that when the triggers for inflammation happen, so things happen to the cell which would normally cause it to cause inflammation, the lack of these pathways prevents it from being able to cause inflammation. So that's what we're trying to do. We're basically taking the body's natural pathways for inflammation and just knocking out one bit of that pathway to make the whole thing not work. So we have two types. They're very helpfully called steroidal anti-inflammatory drugs and non-steroidal anti-inflammatory drugs, which should give you some confidence that we're covering most things here. And so the specific target is what's different between these. So NSAIDs target what we call cyclooxygenase, whereas steroidal anti-inflammatory drugs, SAIDs, target phospholipase A2. So the effect is slightly different. So because NSAIDs target, we shorten it to COX usually, cyclooxygenase, because they target that, and that's a bit later in the pathway, that only blocks the formation of prostaglandins, whereas SAIDs target phospholipase A2, that's higher in the pathway. And so by blocking that, we block the formation of both prostaglandins and leukotrienes. So I think there's a diagram on the next slide, actually. Yep, okay, perfect. So that pretty much that sort of sums it up if you look at the right there. So our SAIDs, they target phospholipase A2, so they prevent the transformation of phospholipids into arachidonic acid, which is our precursor material. COX-1 and COX-2, which we're about to talk about, convert arachidonic acid into prostaglandins. So SAIDs target the first one, NSAIDs target these two. So the reason that we care about there being two types of cyclooxygenase specifically is because they do different things. And one is the good one and one is the bad one. So COX-1 we found in pretty much every cell, and it does a lot of things which are just normal to your body. So platelet aggregation, structural mediation, that sort of thing. And so that's good and normal to have. We don't mind COX-1. COX-2 is our problem substance. Okay, so COX-2 is the one that is produced as part of that inflammatory pathway. So if something triggers inflammation, we produce COX-2. COX-2 then goes throughout the body and causes inflammatory responses. So vasodilation, all of that stuff. You guys remember inflammatory responses. So we have what we call selective and non-selective NSAIDs. So non-selective NSAIDs, they target both COX-1 and COX-2 because they are broadly similar. They're not exactly the same, and that's where the next part of our drugs come in. But they are similar enough that several drugs target both of them, basically. So if they target both of them, then you get side effects from blocking COX-1. Okay, so because COX-1 is important in many different places, that means that we have a lot of GI problems, so decreased gastric mucus, which leads to increased peptic ulcer risk. You can have nausea in a lot of patients, easier bleeding because of its purpose in platelet aggregation, and an increased asthma risk, which is an interesting thing we'll come back to in a sec. Selective NSAIDs, they only target COX-2, which means that they have better GI adverse effect profiles because they're not messing with COX-1, which is important for the gastrointestinal tract, but they do have a higher risk of cardiac disease. So it's very much a toss-up. Not many anti-inflammatory drugs are just overall good. It's typically the weak ones in low doses that are fairly safe, but once you get into the serious stuff, pretty much everything has side effects, basically. So the asthma thing is actually quite interesting because it's a good idea or a good example of how we can think about these biochemical pathways. So the reason that COX-1 and COX-2 non-selective inhibitors lead to increased asthma risk is because they block the conversion of arachidonic acid to prostaglandins, okay? What that means is the body will continue to produce arachidonic acid, but it can't be turned into prostaglandins, which means we'll eventually have an excess of arachidonic acid. So by now you guys probably know that so many of the reactions in your body are equilibrium, so we move back and forth depending on excesses and deficits. So if we have an excess of arachidonic acid and we can't turn it into prostaglandins, a lot of the time it gets turned into leukotrienes instead. And leukotrienes are, among other things, bronchoconstrictors, so they increase your asthma risk, basically. So by inhibiting one part of this pathway, we cause overflow into other parts of the pathway, which is part of our adverse effect profile. Okay, so we have a few drugs that we look at for NSAIDs. So you might have heard of aspirin, which is actually an interesting one because it's often used for completely unrelated disorders. Particularly, we use it as a sort of mild blood thinner, as an antithrombotic. We use it to prevent cardiac events, basically. But it is also an anti-inflammatory drug, as well as being a simple analgesic. So in terms of adverse effects, it has these sort of typical NSAID profile, so problems with the renal function, potentially liver problems as well, although that's not too pronounced, also gastrointestinal tract and bleeding, basically. So aspirin is sort of in its own league because it's an irreversible inhibitor of COX, as opposed to a lot of the other ones which are reversible inhibitors. And it's absorbed in the gut. So gut disturbances can cause problems with aspirin usage, basically. Ibuprofen, also anti-inflammatory and a simple analgesic. So there's the note at the bottom there. So why so many NSAIDs are also simple analgesics is because PGE2, that's one of the prostaglandins, is responsible for sensitizing nerve endings in our pain pathways. So we're about to talk about pain pathways, actually. But the upshot is those nerves convey pain from your senses to your brain. So if they don't work, that means that your body can sense pain at the nerves, but it can't sense pain in the brain. And your brain is what actually gives you this sensation of pain. So by blocking those, unintentionally, really, they also work as painkillers. So that's why you have Nurofen given out over the counter. Ibuprofen, the adverse effects, again, pretty typical, but there's also some cardiovascular risks, which are linked to the sodium retention. So that's a renal thing, partially because it's metabolized mostly by the kidney. I can see in chat we had a question about leukotrienes, which I think Jane has answered pretty well. So yeah, basically they're one of the more respiratory related signal molecules. So they are responsible for all of that puffing up that we have in the bronchi and the respiratory tract as a whole. So if you have more of those, you have a more acute asthmatic response, basically. Okay, diclofenac, that's another one that you probably haven't heard of. Pretty simple. It's very typical of this group of drugs. The most interesting thing about it is that we use it for rheumatoid arthritis, which is as you guys probably know by now, an inflammatory joint condition. So meloxicam, quick note, I think in general, most of the selective COX inhibitors have like ox in them. So like there's like celecoxib, I think, as well as meloxicam here. So they all have names where you can kind of figure out that they're selective ones, and they're all newer as well because they have been they've been developed more recently. So again, simple analgesic, anti-inflammatory, but increased cardiovascular risk. So we get rid of a lot of that gastro and renal adverse effect profile at the cost of an increased cardiovascular risk, as far as we can tell. Paracetamol, not actually an NSAID, but it gets looped in with the other ones quite a lot. I think this is just sort of a misconception thing where people think that it's an NSAID. We don't know how it works, so we can't say if it inhibits COX or anything else. It does work as a painkiller, and it does work as an antipyretic, so like fever and anti-inflammatory to a degree. Okay, so managing the adverse effects. So if they are all messing with the gastrointestinal tract, messing with platelet function, then we can take a few steps to overall reduce the risk. So in terms of the gastrointestinal effects, so you take it with food or fluids because that helps prevent sort of irritation of your gastrointestinal tract, your stomach lining and other parts of that system. So that's pretty typical, if anything. You'll notice that a lot of patients who come in with that sort of peptic ulcers, that sort of thing, they'll say it gets better when they eat food and that sort of thing, because it basically a full stomach, among other things, helps mediate that effect, makes it less irritated. If we do need to use NSAIDs in a patient with a high risk of gastrointestinal irritation already, then we use another drug class called proton pump inhibitors, and we do a combined therapy with those, and that helps manage risk a little bit. In terms of the antiplatelet effects, so blood thinning effects, the most important thing here, assuming that your patient is not planning to slash themselves up at home, is that if you have surgery where they will get cut up and they will bleed, we want to avoid NSAIDs for a while, because by doing so, we can make sure that the blood isn't overly thin and won't overly bleed during the surgery. Okay, so steroidal anti-inflammatory drugs. There are a few different words that all sort of overlap a fair bit. So corticosteroid is sort of the umbrella term for a number of hormones which are produced by your adrenal glands. The ones that we focus on in terms of actually treating inflammation are variously known as glucocorticoids. I think there's also glucocorticosteroids. Point is, they all have a bunch of different similar and confusing names. They all do more or less the same thing. Okay, so the functions of them that we care about are anti-inflammatory and immunosuppressive. So rheumatoid arthritis, part of the reason that it works for that is because they're immunosuppressive, but they also work as generalized anti-inflammatory as well. We use them in adrenal insufficiency because these are natural. So your body should be producing some of these. And if it doesn't, then you have problems. So we will sometimes give them to patients just because they don't have enough naturally. And also for allergic diseases such as asthma. So that's the anti-inflammatory function coming in, basically. So they do have a severe long-term side effect profile. So if you use these a lot for a long time, you will have problems, which is why we went to the trouble of developing NSAIDs. So there's sort of a response to these being pretty bad. So again, you'll see here, the same pathway, the same overall pathway is like exactly the same: membrane phospholipid to arachidonic acid to leukotrienes and prostaglandins. And by knocking out the phospholipase A2 step, instead of the cyclooxygenase step, we can actually prevent both of those groups from forming. And that results in a excess of phospholipids instead of arachidonic acids, which is basically less important for the body because it uses phospholipids all the time. All right, so the mechanism of action seems incredibly complicated. That is a very complicated looking diagram over to the right. It's not actually that complicated. Let me explain. So if you guys think back to semester 1 or even 3-4 bio, you'll remember that the hydrophobic signaling molecules go through the cell membrane because they can, and then they bind to receptors in the cytosol. They form a hormone receptor complex. So in this case, it's like a GCS-GR complex that then moves into the nucleus. It acts on certain parts of the genome. So we call them glucocorticoid responsive elements, or GREs. And that has sort of a dual action. So it both promotes the transcription of lipocortin 1, which is part of a pathway which inhibits phospholipase A2. And we also decrease transcription of pro-inflammatory cytokines, including COX-2. So we have a number of different genomic effects, and they combine together to form quite a good anti-inflammatory effect. There is also a membrane pathway. So the main pathway is when we go through the membrane into the cytosol and then mess around. But there's also some immediate responses. So you'll get a quite fast onset of those, and then a slow onset of these more broad anti-inflammatory effects. The rapid stuff is mostly there's stuff about vasoconstriction, so that immediately counteracts the vasodilation that inflammatory usually brings. And so it's complex, but not as complex as it seems. So the overall effect, we have less vasodilation, which means we have less redness, heat, pain, swelling, pain, all of that stuff. We have less leukocyte migration, we have less histamine release, and we have less icosanoid and cytokine production. So all of those mediators of inflammation are being locked out, basically. Okay, adverse effects, there are a lot of them. So the diagram on the left is more sort of overall corticosteroids. The one on the right is specifically a disorder called Cushing syndrome, which is in the modern world primarily a result of SED use. So literally this disease is more commonly because we gave patients drugs than because there is something initially wrong with them. Obviously there's the inflammatory condition wrong with them, but you get the point. So some of the important or sort of like classical symptoms of Cushing syndrome, sort of central obesity, so your torso, your abdomen, that sort of area, as opposed to your limbs. Something called a buffalo hump, which comes from osteoporosis and sort of buildup of things at the back. Have sort of moon face, which is creatively labeled as moon faces on that. And then you have sort of changes to the skin texture. It's been described by faculty as an orange on sticks. I'm not sure how much I get that particular analogy, but it's there if you want it. I think it's basically a combination of the skin texture that you get, and also the fact that you have central obesity, whereas the limbs may be relatively unaffected. Oh, and one more thing, scarring. So you get scarring of the skin much more easily than before. Okay, and yeah, that's just a final comparison slide about why you would use NSAIDs and SEDs. So the NSAIDs, I should have mentioned before, they don't affect your disease progression. So in corticosteroid or SED therapy, we may have some effects on disease progression, we're not quite sure, but it's ultimately not getting to the cause, we're just knocking out part of that pathway between the cause and the effect, which is inflammation. The other thing is that corticosteroids are sort of selective COX inhibitors in some respect, because, as I mentioned, those genomic effects only include COX-2 synthesis, so not COX-1. Obviously, they have a broader side effect profile, so we can't just call them NSAIDs, but they sort of dodge the gastrointestinal effects of non-selective NSAIDs. Okay, if you guys have any questions, if I went too fast, feel free to chuck it in the chat. Otherwise, we're on to DMARDs with Deepak, I believe.
Yep, thanks, James. Let me share screen super quick. All right, so starting off with DMARDs. So when we're thinking about DMARDs, we're really thinking about rheumatoid arthritis. So DMARDs is a class of drugs used to specifically treat this condition. And a little bit of info about rheumatoid arthritis, a chronic musculoskeletal condition. We generally have a pretty unclear etiology, not sure what causes it, but risk factors that include genetic predisposition, environmental factors, especially smoking, and it's known to affect more females than males with almost 2-to-1 ratio. When I said it's a class of drugs to treat rheumatoid arthritis, that's a little bit misleading because generally for RA, it's all about controlling disease and slowing the rate of damage and decreasing pain, which in turn allow us to maintain function and maximize quality of life. So there's a bunch of different drugs that we think about. Like we just talked about with James, we've got NSAIDs and corticosteroids in this list. We've got simple analgesics as well, like paracetamol. And we've got DMARDs at the bottom. So the role of NSAIDs is generally to control inflammation, swelling, and pain, and it does not really affect disease progression at all. Same with corticosteroids as well. Generally, we don't really, it has a kind of an unknown effect on disease progression. We're not sure if it exactly stops it or helps significantly, but it's used to bridge the gap between initiation of DMARDs and onset of DMARD action. Now, the reason why we need to bridge this gap between initiation and onset of action is because DMARDs are also known as SARDs. So SARDs are slow-acting anti-rheumatic drugs. That's the class of, that's kind of like what it was called before we call it DMARDs now. And by the name slow-acting, we can infer that it acts pretty slowly. DMARDs refer to a bunch of different drugs, like it's under the classification of DMARDs, but the mode of action is pretty different for a lot of them. And it takes a long time to be active, about 6 to 8+ weeks, some take even months. Generally, it has shown to improve function and actually help with rheumatoid arthritis. So it slows the progression of disease and slows the joint erosion. And it does this through interfering with the inflammatory processes that exist and also lead to an overall decrease in pain. Now, we're going to talk about a lot of different drugs with different that come from a lot of different places. For example, methotrexate, typically used in cancer treatment as a folate antagonist, and in DMARDs, it's shown to be an effective first-line treatment with a relatively rapid onset of action, about 1 to 3 months. I just want to note as well that just as for what you should remember, it's really the stuff that's in asterisk. So this stuff is in the ePharmacology website, and it's more likely that they'll be tested in particular. But it's also likely that these names will come up. But I encourage you to, in particular, pay a focus on stuff that's on ePharmacology. The second one is sulfasalazine, a drug that reduces lymphocyte function. We have leflunomide, which is similar to methotrexate, but with lesser research backing it. Hydroxychloroquine with effects on rheumatic, like anti-rheumatic action, but its major adverse effect is retinopathy. So we've got a bunch of drugs. We can actually use them in combination with one another in combination DMARD therapy. And it's believed that it generally has more efficacious action than single DMARD therapy, more favorable long-term outcomes, and doesn't really increase toxicity that much. So it's pretty useful. All right, so there's another way that we can target rheumatoid arthritis, and this is through the idea of targeting cytokines. So we've got a bunch of different cytokines involved in specifically inflammation in rheumatoid arthritis. For example, we've got IL-1, interleukin-1, and tumor necrosis factor alpha, or TNF-alpha. I hope that stands for tumor necrosis factor. But essentially, these cytokines do a bunch of different things that lead to what we see in rheumatoid arthritis. For example, activating osteoclasts causes bone resorption, which causes bone erosion. Chondrocytes causes cartilaginous breakdown, which causes joint space narrowing. Activation of macrophages helps with inflammation, which causes pain and joint swelling. And generally, these cytokines do have inflammatory action in and of itself, which causes pain and joint swelling. Now, the drugs that we call that inhibit cytokines are called biologics, and they are essentially a new class of drugs through the use of monoclonal antibodies, and hence they're pretty advanced or like pretty recent, so it's pretty expensive. But an example is infliximab, which is an anti-TNF-alpha monoclonal antibody, which binds to TNF-alpha and prevents the action of it. So bringing it all together, we talked about DMARDs, combination therapy, supporting things to support it, such as analgesics, corticosteroids, NSAIDs, and the use of biologics. And this is really what we need, or what we think about in treatment of rheumatoid arthritis as a whole. And this diagram really brings it all together. So, yeah. So a little bit about gout. So gout is a condition in which there's hyperuricemia. Hyper meaning more, urase relating to uric acid, and emia meaning a lot in the blood. So what happens is there's either an overproduction in 10% of cases or impaired renal excretion in 90% of cases of uric acid. And this causes a mass of it called tophi to accumulate in the synovial space of joints, the synovium. And when that happens, obviously you get damage of that area, and it leads to intermittent attacks of arthritis when you have gout attacks. So there are a couple of different drugs. You have allopurinol and colchicine, which are the two ones that we particularly want to know. There's a bunch more referred in the lecture, I believe. But allopurinol blocks xanthine oxidase, which is an enzyme that produces the uric acid. And essentially decreased production causes the crystals to eventually dissolve and stops the gout attack. Colchicine decreases leukocyte migration to the site of inflammation and decreases swelling altogether. So that was about DMARDs. I hope that if you guys have any questions, chuck it in chat, and the other PSPlatypus people can take over, because I'm going to continue with pain and temperature. It really should just be called pain, since we covered temperature sensation a while back. But yeah, so we're going to talk about pain for a bit. Before we talk about pain, pain is classified as a non-discriminative somatic sensation, meaning that it's not, we typically can't really locate or discriminate pain. There's different types of pain, and some are more localized than others, but it generally falls under the category of non-discriminative sensations. So pain, if you think about it, it's really a protective mechanism that indicates to us when our body is damaged. And there's a lot of different things that isn't very helpful when it comes to pain. For example, our body can alter our sensations of pain, or alter sensations, to cause dysesthesia, abnormal unpleasant sensations, allodynia, which is pain from normally non-painful stimuli, and hyperalgesia, which is exaggerated pain from noxious stimuli or sensitization of that stimulus. So these are just referring to allodynia and hyperalgesia later on. Pain is detected by what we call nociceptors, or pain receptors. And there are two main types of nociceptors. We have A delta fibers and C fibers. Also, very quickly, allodynia. So this diagram, it's pretty good diagram that helps us understand allodynia and hyperalgesia. So we've got normal pain starts, and that's from where the stimulus generally becomes harmful. But as the pain threshold decreases further, we experience pain in areas where there's not as much harm, or like it doesn't cross the harm threshold for a normal pain to start. And that's allodynia, which is pain from normally non-painful stimuli. And then once we cross the threshold for when normal pain starts, we get hyperalgesia, which is exaggerated pain from the same stimulus. All right, so in this diagram, there's a brief picture about different types of nociceptors. So we've got, but yeah, just keep that in mind. We've got A delta and C fibers. If you guys remember from a prior lecture, the A delta, A beta, and all the different types of fibers are classified according to myelination and speed, with C fibers having little to no myelination and A delta having more. So since it has more, it's generally faster, and it carries sharp pricking pain. And it's also known, A delta is generally more localized as well, or we can discriminate where it's coming from better than C fibers, which is dull burning, which is poorly localized. So we can call this an ouch pain, and this is the groan pain because it's prolonged for a longer period of time, as you can see on this graph here. As for the nociceptors themselves, they really are just free nerve endings, and with a cell body located in the sensory ganglion of other types of sensory cells. It's important for us to know that it's a free nerve ending only, though, for all nociceptors. All right, so going into more classifications. So we have A delta here and C fibers here. So there's a bunch of different types of nociceptors, and I want you to categorize it into A delta and C first. And then within A delta, if you think about pain, pain is really when a sensation becomes indicative of damage. So for example, I can get mechanical pressure placed on your skin, but after some point, if I were to push on it too much, it becomes pain, right? So this means that once you reach a certain threshold of like how much that mechanical stress is, then we start interpreting it as pain. So for example, in type 1 or high threshold mechanical receptors, under A delta, these are really just mechanical receptors that detect touch, but they're so high threshold that any mechanical receptors that are actually stimulated would be indicative of damage occurring there. So we interpret that as pain. So generally, it responds to, this responds to a bunch of different stuff, but it's primarily focused on mechanical response. So first, it mediates the first response to a pinprick. And it's called high threshold because it responds to high intensity mechanical sensory stimuli. It also responds to chemical, and also there's also heat. It also has a high heat threshold. So if there's persistent heat, it becomes sensitized, and then both the heat and mechanical threshold are reduced. We're going to talk about sensitization and how that occurs later, but it's essentially the process of interpreting stimuli as more painful, and yeah, it's kind of like this graph here. It's like us being able to detect pain more. So another type of A delta is thermal fibers. So these have a slightly lower heat threshold as compared to the HGMR and higher mechanical threshold. So it mediates the first response to noxious heat. C fibers, we've got a bunch. So nociceptive, silent, itch, and non-nociceptive. So I want you to think primarily about nociceptive. So that's the key C fiber for pain, and it's polymodal, meaning it generally does basically all the different types of pain. So we have noxious heat, mechanical stimuli, and also chemical, I believe. Silent fibers. So silent fibers are essentially fibers that are silent, which means that it doesn't detect pain initially. Only after tissue damage and subsequent inflammation does it actually cause the unsilencing of these fibers due to the specific cytokines and intracellular signaling molecules that are generated due to inflammation that which act to unsilence these fibers. And once tissue damage occurs, it is a big aspect. It plays a big part in transmitting pain to us. With itch, so we're not talking about nociceptors anymore. So it's just for your knowledge that C fibers also mediate itch. So in with regards to chemical irritants like histamine, and then just non-nociceptive stuff like cold, harmless stroking, like the pleasure touch, and yeah. A bit more about nociceptors. They adapt very little or not at all. And often we talk about sensitization, and that's true. Like it gets greater as pain continues, especially for chronic pain. So sensitization can occur due to inflammatory mediators, which decrease the threshold for firing. So if you see on this diagram here, we have a bunch of different substances and what it does on nociception. And we have a lot of different substances that activate pain, and a bunch of prostaglandins and leukotrienes, which are what, if you guys remember, from inflammation, which sensitize the pain. We have two types of hyperalgesia. primary and secondary. Primary is if it's just the injury region that's hypersensitive, and secondary if the surrounding area is also hypersensitive. And also, just mild stimulation of nociceptors can be felt as an itch or a tickle, which is kind of like these two ones, the itch and the non-nociceptive, which is stroking, like tickling, pleasure touch kind of thing. All right, so we talked about specific individual neurons. Now we're going to talk about the pathways through which these neurons take to get to our brain from the afferent receptors and the afferent fibers. Pain is primarily carried through the anterolateral tract. And the anterolateral tract consists of three main ones: the spinothalamic tract, which I hope you're familiar with or have heard of, the spinal-reticular tract, and the mesencephalic tract. I wouldn't worry too much about these two. Just knowing the name would be enough, and knowing that they're related to the anterolateral tract. But for the spinothalamic tract, we want to know that there's a ventral one and there's a lateral one as well. The lateral one is the one that we're particularly talking about because it mediates pain and temperature. The ventral one is more of light touch, so we don't really worry too much about that. But yeah, as for the total anterolateral tract, the lateral anterolateral tract does pain, temperature, and sexual sensations, and the anterior one does crude touch and itch. And the picture on the right is specifically for the spinothalamic tract of the anterolateral tract. Okay, so this lateral spinothalamic tract is broken up into two other tracts, which is the neospinothalamic tract and the paleospinothalamic tract. We mentioned earlier that 8 delta fibers are highly localized, and we know that they're myelinated more, so they produce more fast pain, fast ouch pain, and they're more commonly seen in the neospinothalamic tract. Slow dull pain, which is generally transmitted using C fibers, is better seen in paleospinothalamic tract. When I say lamina refers to when you cut a cross section of the spinal cord, and it refers to specific areas on that cross section of the gray matter in the middle. Oh, sorry, white matter and gray matter, I think. But neospinothalamic tract exists in lamina 1 and paleo exists in lamina 2 and 3. So for the slow dull pain, only 1/10 of the fibers pass all the way to the thalamus and higher regions, and a lot just end in the lower regions of the brain, like in the medulla. And this is kind of an explanation as to why it's also so poorly localized, because it doesn't get all the way up to our somatosensory cortex properly. But we still perceive pain. A bit more information about the spinothalamic tract, just to jog your memory. So you have your first order neurons that synapse at the dorsal horn and decussate almost immediately at the spinal cord, and then go all the way up to via the second order neuron to the thalamus and then to the somatosensory cortex. And you can kind of imagine where if we have lesions at different aspects of this tract, it will cause a different loss in sensation. So for example, if I cut it here, then I'm just going to lose sensation to the particular part of the body. If I cut it like here, then I'm going to lose sensation to like the entire other half of the body. So if I cut it over here, I'm going to lose pain sensation for the entire left hemisphere of my body. But yeah, there'll be a couple of slides in your lecture, I believe. So we're going to talk about gait control theory. So you guys might have noticed that when you get hurt, when you stub your toe or something, if you rub your toe, it kind of makes it feel less painful. And how do we understand that? And that really is the crux of gait control theory. So if we have a look at this cross-section of the spinal cord, and if you look at lamina 5 of the gray matter, okay, I think lamina is referring to gray matter, but lamina 5 of gray matter, you'll notice that, as you can see, we have a lot of different types of stimuli that innervates there. So we've got, for example, the green low intensity non-noxious stuff and the red and blue high intensity noxious stuff. basically, I want you guys to orient yourself to this diagram here. So what this shows is that the C fibers are the fibers carrying the pain, and the A beta fibers are, let's say it's something else, right? So in the first scenario here, we just have C fibers carrying pain, and that causes projection neurons to fire, and then pain is transmitted. In the second diagram here, when you have C fibers carrying the pain, and also you're rubbing it, so you feel other sensations as well, it is believed that this A beta fiber causes an activation of an inhibitory interneuron, which inhibits the final projection neuron, so you don't feel the pain that much. Or like you lose, you don't feel stuff that much, even in the presence of a firing nociceptive C fiber. But yeah, that was that. So when we talk about nociception, we've broken it up into neurons, into tracts, but really these are the four main steps. So we have transduction. Transduction is conversion of the noxious stimulus to a nerve signal at the receptor. Transmission is from the nerves traveling from the receptor to the brain. Modulation and perception we'll talk about in a bit. So just transmission super quickly. I just want to, this is a slide talking about the first order, second order, and third order neuron, but I've already mentioned that. But yeah, essentially at the dorsal horn and at the thalamus or any higher center area. So modulation. Modulation refers to, we talked about ascending pathways to the brain from receptors, but these are descending pathways that alter the perception of pain. So the cortex and thalamus essentially can stimulate and send nerve impulses down to the periaqueductal gray, which is found in the midbrain, or PAG. So this PAG, upon control from the thalamus and the cortex, it sends descending inhibition down to the dorsal horn. So if you guys remember, the dorsal horn is kind of like it's where the first order and second order neurons interact, right? So it sends descending inhibition onto the dorsal horn, onto another inhibitory interneuron, kind of like what we saw in gate control theory. And here's a better diagram to illustrate it. So we have PAG, descending corticospinal tract, onto this little red structure here, which is the interneuron releasing enkephalins. Enkephalins are essentially endogenous opioids. And these are essentially small neurotransmitters. Okay, so when this interneuron is activated, we get small neurotransmitters being released that bind to opioid receptors on the nociceptive afferent fiber, or the C fiber. So once the enkephalin binds to these opioid receptors, it inhibits firing of this nociceptive afferent and kind of mutes it, which decreases our pain. So yeah, we have ways to modulate pain through descending pathways. Last one is perception. So this is when the patient becomes conscious to the pain, when the signal reaches the cortex. All right, so very quickly, there's two different types of pain. So for example, we have somatic pain and visceral pain. Somatic pain refers to pain originating from the skin or musculoskeletal system. So it's really like when you get stabbed, or like when you get poked and stuff. It's never really referred, and it's just, it's aching and throbbing on the surface. It's typically evoked by mechanical tissue injury. It's sharp, precise, and well localized. And everything's the opposite for visceral pain. So it's from organs, and it's usually referred to the skin. So we're going to talk about referred pain on the next slide. It's difficult to characterize it. It's not really throbbing, aching, sometimes just unpleasant sensation. It's not primarily due to mechanical injury. It's more like inflammation and ischemia, which is still tissue injury, but not mechanical. And it's also pretty diffuse and vague and hard to localize. So referred pain is essentially just visceral pain that is referred to the skin surface. There are a couple of different ways for us to understand how referred pain works. So one is the common dermatome hypothesis. So this is essentially saying pain is referred to a structure that developed from the same embryonic segment. So for example, the heart, which originated near our pharynx, or like the upper region, is going to be referred to our left arm, jaw, neck, and area. Yeah. Same goes for like other organs here, since they receive the same innervation from the start. But yeah, you guys will learn more about embryology next year, so don't worry too much about not understanding this fully. We have another one called convergence hypothesis. So this is essentially when branches of visceral pain fibers, so for example from the heart, synapse at the same second order neuron that receives pain signals from somewhere like the skin. Hence, if activation from these visceral fibers, these visceral pain fibers is so strong, we believe that our brain can misinterpret that as pain coming from the skin, because it's synapsing to the same second order neuron, and that's convergence hypothesis. And yeah, that's the end of pain. And if you have any questions, chuck it in chat, and I'll hand it over to Marwan.
Thank you. Can you guys see my screen? All right. So now we are going to talk about biostatistics. So as we learned before, that biostatistics is the analysis of epidemiology. It's to understand what this number means, or how can we apply this number into context. So we have hypothesis testing, which is a statistical test to assess the probability that the observed results would have been arising if the true result was something different. And we have two terms here: null hypothesis and alternative hypothesis. Null hypothesis, where there is no difference in the population and there is no association between the two variables or two samples we are observing. However, the alternative hypothesis indicates that there is significant difference between the observed and true result. For example, if we said that the null hypothesis no effect on cholesterol levels, and the alternative hypothesis, which is the opposite of this, that statins lowers cholesterol levels. So there's something we have called p-value, which is the opposite of the CI value that we've talked. So if the p-value is less than 0.05, we'll reject the null hypothesis and accept the alternative. And if it's higher than 0.05, so this indicates that there is insufficient evidence to reject the null hypothesis, and it might be actually be correct. So the p-value is the probability of incorrectly rejecting the null hypothesis. And we have type 1 error and type 2 error, which we'll talk about in the next slide. Yeah. So type 1 error means that we reject the null hypothesis where it's actually not true. So for example, as we can see in this picture, the doctor telling the male patient that is pregnant, while the null hypothesis is not being pregnant. So we reject the null hypothesis, and well, while it's true that this male patient isn't pregnant. Type 2 error, which is called also false negative, when we accept the null hypothesis while when it's actually not true. So if the null hypothesis is not being pregnant, in the second picture, as we can see here, the doctor telling the female, and obviously can see pregnant patient that she's not pregnant. So the doctor accepted the null hypothesis while it's not true. And we have some statistical tests or t-tests, and these tests we use for continuous data. So we've learned before that there are two types of data, categorical and numerical, and one of the types of numerical data is continuous data. So these tests we use to test our hypothesis, to compare between the hypothesized and the actual value, or to compare even between two groups, two samples. So we have one sample t-test where we compare the sample mean to the hypothesized value. Two sample t-tests or unpaired t-test. We will compare two means from separate groups. So we have two samples and two means, and we make comparison between them. So male versus females, and we compare their height. Then we have a paired t-test where we compare before and after. So the same variable, but before and after exposure, for example. And the final t-test, which is ANOVA, which we compare of the mean of more than two groups. We have more than two samples. Finally, we have these two tests that we use for categorical variables. We have chi-squared test and odds ratio test. So chi-squared test is the same as t-test, where we calculate the chi-squared value and use the table of the degrees of freedom table that we talked about 2 weeks ago, the t multipliers table, to find the p-value, and then we can analyze this. However, in the t-test, when we find the p-value is lower than 0.05, we will prove that there is a difference between the two samples. However, in chi-squared tests, if we found that the p-value is lower than 0.05, then we'll prove that there is actually a relationship exists between these two variables. Then we have the odds ratio. We can calculate the odds ratio using, for example, this table, where we multiply A by D and divide this value by B multiplied by C. Or we can use computer to get the logistic regression. And this odds ratio actually used for case control studies. If the odds ratio less than 1, then that means that the odds of exposure among cases is less than in controls. If it's higher than 1, the exposure among cases is greater than in controls. And if it equals to 1, the exposure is the same for cases and for controls. We might also have relative risk. We need to calculate relative risk, but we use this usually for cohort studies or randomized control trials. And finally, we have this table that summarizes all these tests that we use to test our hypothesis. And thanks to PSPingo, I took this table from the slides. So yeah, that's it. Thank you so much.
All right, perfect. Thanks for sticking around. And to the people watching online, first of all, we'll let you run off to your the Q&A or Money's Point lecture or whatever it is, because I know you guys like doing that. We're getting a lot of questions about assignments. We are trying to set up a session. Hopefully we'll try and do something in the next 2 weeks, and that should be able to hit all 3 of your assignments. We are not 100% sure when that'll happen though, because we need to coordinate that with our schedules and your schedule as well. So for now, if you have questions, please feel free to send them to us or chuck them up in the Curious Cat. And that'll be the easiest way to get those answered for now. So chuck them up if you have any questions. We'll do our best to help you out, and we'll try and set up probably something like a Q&A or a basic presentation session. So we'll see how we go. Thanks so much, and see you next week.
Thanks, everyone.